So for today's talk, we're delighted to welcome Dr. Walter Buzz Stewart, the CEO of Medcurio. Buzz has 20 years of experience leading innovation projects within healthcare system research and development. He has expertise in digital solutions, machine learning, and practice-based rapid learning, as well as a successful track record bringing startup health companies to market. Prior to co-founding Medcurio, where we met, Buzz served as Chief Research Officer and founder of Research Development and Dissemination at Sutter Health. He was Associate Chief Research Officer and founder of the Center for Health Research at Geisinger Health System, Vice President of Research and Development at PCS Health, and co-founder and president of a clinical trials and survey research company. Buzz is a former professor and current adjunct professor at Johns Hopkins Bloomberg School of Public Health, and Buzz has published more than 400 academic articles on health and healthcare, and he refers to that as his hobby. Buzz has several decades of experience in health research, running digital health and analytics R&D units in those two health systems we mentioned. And he co-founded Medcurio with Kristen Wilson Jones to solve the biggest headache in his work life at the time, making it easy to get access to and effectively use healthcare data. This week, Buzz will share his broad expertise and insights into the influence of data analytics in the healthcare industry. Buzz, take it away.
Great. Thanks, Gary, for that introduction. And it's a real pleasure to be here. For those of you who know Gary, he has a kind of an infectious energy and, suggests ideas. And it's sort of easy to say, yeah, that's a great idea. I'll do that. And then as I took on this topic of that we labeled sort of high impact analytics, I thought, what have I gotten myself into? Because this is a big topic, and I could do the easy story, which is to say, just pick up an important problem and make sure lots of data are used in that problem, and invent something really smart, and then figure out how to put it into practice. And then as I got into the details of sort of formalizing the way I think about it, I thought, okay, well, this is the introduction to a course, and so. I'm gonna to some degree talk at a high level. In certain areas, I'll get into details. I'm gonna say some things that are obvious, but often I think it's important to sort of point out the obvious things that we face, because often we forget the things that are obvious, and behind those obvious things are some really important fundamental challenges. And so, and as Gary indicated, I'll state in the interest of full disclosure, my own biases around what I consider to be the big challenges in this space, and the reason why we started Medcurio, which is to really solve the plumbing problems around data access and workflow, data access and data flow, because in many ways that's the barrier, at least that I faced at both Geisinger and at Sutter, around implementing cutting edge solutions. And so with that, I'm going to cover sort of four topics. I'm going to spend most of the time in the first two: value creation in healthcare, what that means, and how we do it, and then how do we effectively use healthcare data to create value. And then I'm going to close with some comments around the barriers that we face in trying to achieve that, and what it would really take to eliminate those barriers in a way that makes the effective use of data very scalable. Before I get into that, though, just a few comments that I wanted to make, a kind of a level set about the market, because I've been saying this for over a decade, and I find it remarkable about how the two sides of the healthcare market are unfolding, as we have this sort of constant in the exponential growth in both healthcare data and knowledge. So these are both growing at remarkable rates, unlike any other business sector. And then in parallel with that, we have a continued rapid growth in the investment in digital applications and healthcare analytics that continues to explode. There continues to be widespread interest. But if you are on the healthcare system side or the healthcare delivery side, many executives and many folks who are on the front lines are scratching their head and wondering, where is the value that we're getting from all these data? It's that sort of contrast and the two parts of the market that everybody's trying to bring together in a way that makes healthcare delivery more successful. And in that context, at least in my own experience, and having lived in 2 different health systems and now having reached out to a lot more, the thing that I think is important to recognize for anybody who's in this business or inventing solutions is that, of course, we all want to get partnerships with healthcare systems. They have the data and the patients, but what's impressive is how variable the ways in which data are being used across health systems. I almost would say that once you've experienced one healthcare system, you've experienced one healthcare system, because there's so many things that vary in terms of how they are going through the journey of using data effectively. And even within an individual health system, there's at least 2 different groups to think about. One is the data users who want data more effectively to get their job done. And then there is their high dependence on the data providers. And that usually is the IT department that sits under the CIO. And often those 2 groups are in conflict. You would think that they'd be aligned in many ways, but there are challenges in making data available that often puts them in conflict in terms of what their priorities are. And so I always like to keep this framing in front of me, because when I talk to a healthcare system, I want to know in advance a lot about how they're using data, because that influences not only my conversation, but how I would talk to them about solutions. So let me start the conversation with value creation and how that happens in healthcare. And there's lots of different views on this, and I'm going to talk about one particular view that I've adopted that I think is fundamentally important. But before I do that, I'm just going to describe or quickly go through scenarios where healthcare analytics could really matter, and it could create high impact. And those are sort of summarized here from the top, which is a somewhat common scenario where you have performance run charts and ways of using those run charts to motivate improvement in care on the ground, to managing a physician's inbox and offloading the work of that inbox in some way with AI and other tools to free up time, one of the banes of existence of many physicians today and a common source of burnout. And another area would be the challenges that specialists face in the diversity of data that they need to do a better job in delivering more precise care and the access to knowledge. And having a kind of, I'm sorry, this one's about appointment slots. Let me go to the knowledge graph. Having a kind of solution for specialty practices where an AI-driven process can detect when a record is open, they detect the context, the patient, and the right content is delivered to the physician as they're engaging with the patient in a way that allows them to provide more precise, more comprehensive care. The area of prior auth, this is an area where virtually everybody believes should be fully automated. We know where all the data are. We know what the data requirements are to make decisions. And there's just a little plumbing problem in between that limits our ability to make this a fully automated procedure. But if it could be fully automated, it frees up substantial time, not only for providers and their staff, but also it gets more timely care to patients. And then there's a whole slew of predictive models that could bring value. One of my favorites is pre-diagnostic heart failure, to the extent that we could get ahead of the curve and that we had treatment phenotypic diagnostics. It could help enormously. So these are examples of where I think analytics could be high impact. And one of the points that I'm going to make is that whether or not it's high impact actually depends less on the analytics and a lot more on other things. And so in my view, high impact analytics has at least 2 really important parts. One is identifying high value opportunities, and the other is effectively using data. And both of these, I think, have to be sort of operating, I think, for analytics to have high impact. And so the space is somewhat narrower in terms of where analytics could really matter and have high impact. I'm going to move this. Hold on. So let me just drill down a little bit on high impact, the components of high impact. So one side of it is the high value opportunities, and I'm gonna focus on processes of care, and the high value opportunities are really around influencing those processes. And there's really sort of two categories of processes to think about. One is the processes that are involved in care delivery, and the other is what I'll call structural processes. This comes from sort of Donna Beaton's framework of structure, process, outcomes. And often we think of structures as facilities and things of that sort, but in the modern era, there are lots of processes that are really structural and not directly involved in care delivery. And the high value opportunities really are around those processes that are frequently used, that are complex, costly, meaning that there's probably a lot of labor cost involved, and that are critical to business operations. And a high value opportunity at the end of the day has to be one where there's substantial room for improvement. There are things that we do where you really can't change it much. And then last, where, of course, for the context of this presentation, where data can be used to actually improve the process. And then the effective use of data, I think, involves at least all the items that are listed here, perhaps more. One of the things I always emphasize is that effective use of data, first and foremost, has to anticipate the need for something that's durable and easily adaptable. So whatever solution that you have that's going to use data, those two features, I think, are really important. And I'll come back to why they're really important in terms of having a sustained impact. And then there are a set of things, I think, that have to happen in a somewhat seamless way for data to be effectively used. You have to be able to access all of the right data that you need. You have to be able to orchestrate those data into a flow. It could be a simple flow or a complex flow if we have multiple data sources, but there is, at the end of the day, a flow that has to be managed. And the analytics, which may be the secret sauce of your solution, has to be integrated into that flow. And then at the end, the overall process has to connect to some output or endpoint that is actionable. If you don't have that, obviously, then it's hard to act on the data. What I think is really key, given how rapidly, how fast data are growing and how rapidly knowledge is changing, is you have to have a relatively easy way of keeping pace with changes that are relevant to your solution and adapting your solution to those changes. Because if that's a heavy lift, then at some point you're going to be stuck in time and not keeping pace with the evolution of knowledge. So let me spend a few minutes on the value opportunities. And the first question that comes up, I think, when you think about value is, who is the value for? Now, I would say in most business sectors outside of healthcare, answering that question is really straightforward. It's the customer. And especially in the 21st century, if you are not focused on the customer as the primary focus of creating value, you will eventually lose market share or be acquired. And so in almost all of the business sectors, the customer is the primary focus for creating value. It's remarkable how long healthcare has resisted this construct, and in particular in the US. In fact, it's interesting to think of the ideas that we've invented over the last 20 years to move us in a direction where the patient is the primary focus for creating value. So the notion of value-based care had to be invented to get us to realize that the patient is the focus for actually delivering value-based care. And if you're not familiar with Michael Porter, he's a Harvard professor of economics who migrated from other areas of economics into healthcare at the turn of the century. And he's written some really important work, and perhaps one of his more sentinel writings is a 2010 article in the New England Journal of Medicine titled "What is Value in Healthcare?" And it's a really well-written article, as much of his work is, and it has like a 60-page appendix that goes with it that drills down into the details, and it's worth reading if you want to understand his framework for value, which I find compelling. And it's straightforward conceptually. Obviously, there's lots of nuances, but in his framework, and it's one that I think of a lot, the patient is the focus for value creation. And value is defined simply as delivering an outcome for at a cost. And he frames it around episodes of care from the beginning to the end, however you define that episode of care. I think that gets a little complex when you think of prevention, but I think it could still be could be applied there. And value creation is simply increasing that ratio of outcome to cost. And so it could mean that you improve the outcome while holding the cost constant, you decrease the cost while holding the outcome constant, or you improve both in a way where the ratio goes up. And so that's the framework that I'm going to work from as I talk about value. The other thing I want to just mention is another dominant construct in healthcare called STEEP. This was really evolved from the Institute of Medicine, I think is a cornerstone around how value gets created and the mediators of value creation. There's a lot of I would say really good stuff that's been written about this and the levers for creating value. Some of these like safety, timely care, efficient care, effective care have a lot of meat behind them because they've been studied a lot, and a lot is known about how to improve safety or timeliness of care or efficiency of care. For example, in healthcare, 25% of our costs are probably waste, and so there's a lot of opportunity there. Some of the areas are not well specified or clarified in a way where you can connect the dots between, say, equitable or patient-centered care and value creation. I think everybody, myself included, or many people think that there is a connection, but they haven't received the same level of attention as some of these other areas. But I think that value is certainly there. And I don't think you can think about the value proposition for a high-impact care without thinking about the care setting. And I have a kind of quick summary here of a lot of stuff to think about, but I wanted to make a few key points. When you go from avoidable inpatient care down to patient self-care, there's lots of other slices that you could create in this pyramid, but certainly the denominator is substantially larger if you're at the bottom of the pyramid. And long-term prevention is more possible if you're at the bottom of the pyramid. In fact, I would say that long-term prevention, the notion of long-term prevention, is not a healthcare delivery product. I think that healthcare delivery was invented to fix problems. It's not a wellness business. It's my own personal view. Whereas long-term prevention really involves both wellness and patient self-care in a way that that creates long-term reduction in risk. It makes me think of dental healthcare and the invention of the toothbrush, which was at the beginning of World War II. And the enormous impact that had, and that was all self-care, and the enormous impact it's continued to have as we think about individual self-care, dental care, and how critical that is to overall dental health. And we have lots of other areas of health where I believe the high impact value is going to be on enabling people to more easily manage their own health, to be informed about it, and where long-term prevention really can be implemented. Outside of that, we're dependent upon the care system to fix problems. And outside of that, the cost of care goes up as you go up the pyramid, the risk from care goes up substantially, waste goes up, and where our focus really is near-term prevention. And in my view, near-term prevention means in the next 2 years, no more than that, because healthcare delivery, frankly, is not that strongly interested in a time horizon beyond that, and certainly payers are not. But where the seat of near-term prevention largely rests first with primary care, and where there's a lot that can be done there, I think, in a way where high impact analytics could be transformational. So with that framework, I want to go back to Porter's framework. This is a figure from his article, where he has on the left the initial condition that a patient might come in with. Again, he thinks about an episode of care and how that gets managed. And on the right is the health outcome. And we're trying to deliver that outcome. We're trying to deliver the best outcome at the lowest cost. That's the value framework. And in this, there are two dominant sources of processes. There are care processes that directly influence outcomes, and I would say involve lots of expensive knowledge workers. It's not that we don't need those knowledge workers, but I want to come back to what it is that they do with their time. And then there are structural processes that we know indirectly influence care processes and accordingly outcomes. While they involve less expensive knowledge workers, those knowledge workers are still costly. What's interesting is if you've lived inside of healthcare systems or if you've interacted with them, the care and structural processes are functionally linked to each other. But sometimes you think that they just simply operate completely independent of each other and don't seem to talk to each other. And it seems that way because it turns out that the data systems and the workers actually behave in that way. So you have these processes that are interdependent, influence each other in a way that that reveals gaps in terms of how we can make them function better. And then on the outcome side, that's obviously, in my view, the target for creating value. If you follow the principle of managing what you measure, if we don't measure outcomes, or if we don't measure them well, or if we don't measure them precisely enough or frequently enough, it's virtually impossible to know whether we're creating value or what value we're actually creating, or to improve on that. So measuring health outcomes is a critical part of the value proposition, and getting to a place where we can create more value. And then the indicators are things like labs and other measures that give us insights into mediators or how a patient is doing, that they might influence outcomes, or they might modify the ability of a intervention to influence the outcomes. They could even include behavioral health and things of that sort. And so this is a framework that I find really useful to go back to. This is a really complex table. I'm not going to spend a lot of time on it. There's a talk just to be given on this, but I'm presenting this just to make the point that there are a lot of care processes and structural processes. This is just a sample of those processes. But when you're thinking about high impact analytics, in my view, it naturally brings you to thinking about, am I working on the care delivery side, or am I working on structural processes? Because value can be created in both, and data are heavily used in both. and the opportunity or the levers for creating value, whether it's timely care or safe and effective care, differ in terms of what you can do around each of these processes. And they also differ in terms of the impact that they have on care settings. And certainly the ability to expand impact depends on whether or not you simply need electronic health record data, or whether it would be valuable to have other kinds of data that you can bring to bear to influence both the process and the outcomes. And so I bring this up because I think that talking about the candidate processes and the priorities for where high impact analytics could matter naturally brings you to this space and thinking about where you're going to touch data in a way to improve outcome or reduce the cost of care. And then last but not least, the value proposition around the patient is fundamentally important. I would say that if we simply rely on care and structural processes to create value, we will be chronically constrained in terms of what we can achieve without substantial patient engagement. And I say that because there's lots of things that we can do with the patient that are low cost, that have to do with the experience that they have, their satisfaction with that experience, and the care that they're receiving, which strongly influence their engagement. And if they're engaged, they're going to be more adherent. And if they're more adherent, they're more likely to have a better outcome at a lower cost, and they might be more interested in education and self-care. So all those things go together. And it is an area where enormous impact, not just for long-term prevention, but certainly for near-term prevention, whether it's post-surgery or managing a chronic disease, can be substantial. And I would say that a gap that we face is not having high-impact analytics that allow us to more seamlessly deliver these kinds of support services to patients in a way that creates value. And I would also say probably the incentives are not there. And then lastly, I'll just mention that patient-generated data, I think, is fundamentally important. I think it's increasingly important, but I also would say that there's a lot of areas of patient-generated data that may not matter. And it's an area where I would say we've not thought about critically in terms of how extra data enables us to more precisely manage cost, more precisely manage improvement in the outcome, more precisely motivate a patient on what to do, give a provider more insights into what to do with the patient in terms of precisely treating or managing whatever condition they may have. But I think that patient-generated data is an area where the opportunities could be substantial. The hard part, I think, is not falling in love with the notion of just generating data, but thinking first about the practical value of those data and to whom it's practical, and how it might influence the outcome and the cost of delivering that outcome. So with that, I'll just come back to this figure that I presented in my own sort of thinking around where the opportunities are. And I naturally separate the opportunities into the sort of two major domains that I see that are not just confined to healthcare. It's dental care. It's all areas of sort of services where there's the healthcare delivery things that happen, and then there's patient self-care, and there's I think there's high impact analytic opportunities or high value opportunities, I think, in sort of those areas where we can effectively use care separately for healthcare delivery as well as for self-care. It's interesting if you look at, and this is just one indicator of where the money is going in the last year. This is from Rock Health. I'm not going to spend a lot of time on this, but it's interesting to see on the left-hand side where the investments are and how much what I would call a consumer focus emphasis is a dominant theme, and I think it's for obvious reasons. I think in terms of ease of implementation and things of that sort, as well as direct-to-consumer frameworks that allow startups and other companies to reach the consumer directly in a way that appeals to them. And this is likely to continue in a very significant way. I would say a fundamental gap that we face is there's a lot of areas of patient self-care where we'd like to connect the data that they generate in a seamless way that enables a physician or other provider to use that data to help that patient or to educate them or to do something more substantial in a way that that leverages those data. That there's real challenges in sort of taking advantage of that.
So Buzz,
yes,
Gary, I'm just going to interrupt here for a second. Thanks. So far, this has been spectacular. So just getting down clinically and a little bit more practical. I mean, it's quite obvious. We see it on the venture side. We see it on the network side. You know, the slope of the curve of the amount of technology that's being developed now to non-invasively capture data is overwhelming, frankly. And you know, I always love that term, garbage in, garbage out, right? So we're collecting all this data, you know, more data than we could probably ever use. And even the management of that data and the storage of that data becomes an issue in its own right. But there seems to be a continued value in generating all this data. But as you point out, it's going to be important, one, to be able to capture this data in real time and analyze it in real time in a way that's valuable to, let's narrow it down to the patient provider interaction, right? How does the patient access it in a way that's valuable to them, sans the provider, right? How can I use this data that I'm generating and have systems in place to help me evaluate preventatively and from a chronic disease management perspective? How can I be a better patient? How can I be more compliant? How can I use this data? And then on the provider side, as you and I have spoken about numerous times, is that providers can get overwhelmed too, right? Because they are now being given access to data which they've never had before, or at least volumes of data that they've never had before. And how do they use it without having algorithmic decision support systems? Because at the end of the day, I was having this conversation yesterday with an orthopedic surgeon. It's like, Gary, I have 15 minutes to spend with the patient. I'm not going out of the EHR, number one. And number two is, if the EHR just gives me a bunch of data, that doesn't work for me. Give me red light, yellow light, green light. So how do you see that as, how does it fit into the value framework to be usable and improve care, decrease cost, and actually make us more efficient?
So let me, it would be great to have just a session on this topic on patient-generated data, because I think it's a very important area and the nuances matter. But in the interest of time, let me just take two scenarios. One is blood pressure. It is remarkable for something that's so fundamentally important to improving health, how little data physicians rely on to make a treatment decision without validating that they're actually influencing the patient's blood pressure, right? Because the decision is based on somebody coming into a clinic, and then you might measure the blood pressure 3 times, and then you don't know if the patient has white coat syndrome, or we know that blood pressure varies by time of day and season of year, and we're relying on that simple measure with the notion that we can manage success based on that infrequent measure. So that's an important area where the density of data matters a lot, and where we have increasingly reliable and valid devices that people can use at home to get more data under a diversity of scenarios, from morning to night, and where I think patients could be easily motivated. The challenge is that the data We don't have an easy way to package that data, get it into the electronic health record, to summarize it with elegant analytics that give the physician a guide on inadequate management of their blood pressure, too much variance, all those things that you'd like to know, but where we don't have any way of doing it. So blood pressure is an example where the data really matters, but there are real substantial barriers. If you take serum glucose management, and if you're pre-diabetic, it's remarkable the stories that I hear about the devices that tell you, what they give you a spot understanding of how your serum glucose is changing, and the insights that you get from something that you eat and moments later seeing what happens, and how impactful that is on human behavior once you understand what that spike means to your pancreatic and vascular health. So I think those are areas where one is more sort of an easy way for self-care, where somebody can learn quickly through data and having simple ways of presenting it. The other is managing a fundamentally important mediator of health, where we have great treatments, but where I would say that because we don't measure it much, we can't really manage it that effectively. And so there's a lot of blood pressure out there that isn't managed effectively. So yeah, I don't know if that answered your question, but those are sort of two scenarios that I think about a lot.
Yeah, it does. And if you think about it, it's actually, interesting because, as our network and fund has an investment like that, where we can now capture continuous blood pressure, which before took an invasive monitor to accomplish. And same thing, now, I mean, it's understood that we can get continuous blood glucose monitoring under all circumstances. So it takes you in a couple of places. One is it becomes once you start being able to collect all that data, the practicality of it is that you can start to use it preventatively, because now you can collect the data, apply algorithms to it, and prevent, basically inform patients before something happens, in the direction in which you're going, your behavior, your activity is leading you in this direction. And then on the other side of it, which I find fascinating because it's evolving at the speed of light, is digital therapeutics. Because now, if you're able to monitor, Alan Zhang, just posted on the chat, streaming near real-time data is definitely more valuable to provider patient than batch or micro batch data. Is if we have continuous real-time data coming in, you can now use that to actually institute precision therapies based on that patient. Because if some patient has a recurrent level of activity or type of activity that's worsening their chronic disease or their chronic disease management, that can actually be corrected. It's almost a little bit of DBT, behavioral therapy, that could be used for hypertension or diabetes management, because you can preventing that. So it's fascinating where we can go with all this now that it's here.
And I think that I think those are all really important points. I think one of the keys is understanding the density of data that you need for whatever problem it is that you're solving. So if it's somebody whose blood pressure is difficult to control, the specialist is going to want a deeper understanding of their blood pressure variation, and the denser data matters a lot. But this is where high impact analytics requires sort of knowledge-based analysis of those data to give a guide or some decision support around where they see the vulnerabilities, because then that rapidly gives the specialist a sense of narrowing what kind of intervention might be optimal versus the way in which we do it today, where there's a lot of experimentation. So I think this is an area that warrants its own discussion because it's such an important area. But it's also a balance of sort of saying, I mean, people fall in love with dense data, and then they discover that nobody wants it, and it's because either it's too dense and unnecessary, or they haven't sort of translated it in a way that makes it useful in the way that you just described, that red, yellow, green kind of light framing.
Right. Okay, great. Yeah, continue, please.
So, when I think about effective use of data in the framework that I've laid out, it's really, there's sort of two targets that I think of: maximizing steep care, and that's missing an E, and then maximizing patient self-care. So these are the sort of go back to the two domains of influence in terms of where data could really matter and where high impact analytics could matter. And when you think of high impact analytics, or certainly I would say when I think about it, it's recognizing that it doesn't exist in a vacuum. And it was the bane of my existence, is I wished it did exist in a vacuum, because then my life would have been easier. And so you have to think about the data flow coming in and the information flow coming out that's required to sort of optimize what the analytics can deliver. And so this is just one sort of representation of that. There could be many more boxes to really characterize what the process is like, but in any data flow, you need a trigger. And then you go through a series of these steps from left to right to getting access to data, to processing it in a number of different ways. And then ultimately, you've got to sort of tee up some output that translates into the right-hand side, which is one or more of a number of actions that you have to take, whether it's documenting, whether it's prescribing, whether it's deciding what to do, whether it's passing a message on to somebody else. But there's lots of different kinds of outputs that could come from this. And this is a simplified version, obviously, of a data flow, because these are typically iterative, both within the flow and between flows. But the reason why I bring this up is I find it a useful framing. And I like to always go back to what I consider to be the most common use of data in healthcare, which is manually. And manually means that you're doing all the work for getting the data and integrating it into your own workflow. And that process involves a trigger, which is, I'm going to use the clinical setting, but there's lots of different settings that characterize this. And where I'm going to access the data, I'm going to iteratively view it. I got to store it someplace. And if I'm young, that probably works really well. If I'm older, it doesn't work so well. And then I've got to go through this iterative process to figure out what it means. But I'm going in and out of views. And then at some point, I got to sort of summarize and decide what to do, and then I've got to act. So that's the human process. And this is where we have in healthcare knowledge workers everywhere. It's not just in the clinic, but it's in all those structural processes, expensive knowledge workers who I would say spend a significant amount of their time doing $10 an hour tasks and working well below their license. And the opportunity, in my view, is in taking those $10 tasks out of the work and allowing knowledge workers to work at the top of their license. That's how we actually create real value with a knowledge workforce. And I'm not going to spend time on what's in the lower part of this, but I will say that every provider experiences this when they use an electronic health record, and all the things that can happen from the time that they access. In the moment, they may forget all the data they need to see. They know they're on a clock. They have to get everything done within a period of time. They have to connect the dots among different views of the data. And ultimately, they have to translate all of this into a process that leads to a decision. Years ago, when I was at Geisinger, we created this cartoon that we called the squeeze. And the squeeze is the encounter starts out, okay, but then it unfolds in a way where the visit ends before you could actually get everything done. At the end of the day, you got a couple hours of work where you're documenting and closing records and doing a lot of things that really should have happened in the encounter, but were really impossible to execute on. And so that is the sort of norm everywhere in all clinical encounters, whether it's a nurse on an inpatient unit, whether it's in the ED, whether it's in primary care or specialty care, that this is the world of manual use of data. And I want to sort of switch, just a few other points that I'll make, that while the focus is on electronic health record data, there are a lot of folks who are getting excited about all of the other data that we could access to improve care. And I would say that that's a dream in the manual world of using data, because nobody really has time. In many ways, Gary, along the lines of what you were describing, right? There's already a lot of useful data that nobody can get access to because we haven't made it easy to represent in a way that makes decision-making or understanding of what the patient needs easy. I'm just going to quickly switch to what I consider to be the second most common use of data, which is retrospective data analytics. And this is an important area, and I would say that for 80% of healthcare systems, this is what they do with data. This is the cutting edge for them. And the cutting edge of the cutting edge in retrospective data analytics is really around performance analytics, and that is analytics that generates a temporal trend of how I'm doing, and where I can hook a PDSA management process to this in a way that I might combine with provider incentives to get things done. And so this is a process that leading health systems took on a decade ago and mastered. When I was at Geisinger, this was a very common theme we were involved in. And that process involves the IT department. It involves having an analytics team that's generating that analytics on behalf of a unit. It might be primary care. Primary care, for example, has to organize a group that's managing a kind of PDSA process, and then they're communicating that to each of the clinical units. But then at the end of the day, it still has to go through that process on the right. And it's not that this process on the left can't influence this. There's clear evidence that it can. When I was at Geisinger, we had a primary care diabetes program that we implemented around getting primary care physicians to do 12 things every 3 months with diabetes patients. It was really a phenomenal undertaking. And my team looked back after this program was going on for 6 years. We looked back at what happened. And we had an exquisite control group because there was a health plan that had patients that were using the Geisinger Clinic and not using the Geisinger Clinic. And the data showed that this program, just this diabetes management program, reduced the risk of heart attack and strokes by 25%, and started after about 2 years. It was a phenomenal impact. But I can tell you that the people here who were managing this process, when they left, this fell apart and the impact was lost here, because chaos is the norm here. And while with a lot of effort, you can drive improvement through here, it's constrained in time and not durable. That this is not a durable process, but for a lot of systems, this is all they have. That leads me to sort of some closing thoughts, which is using data in real time. That this is where high impact analytics really works, because of how close it is to the point of action, because of the opportunity value that it creates, because of the level of trust by those who use the data, and the likelihood of adoption. All those things sort of go together. And I would say that if you have the analytics world is way ahead of the data flow world, and that we have lots of fabulous evolving analytics that can take a lot of work off of the physician and actually allow the physician, for example, to work at the top of their license. But you could say this about nurses, you could say this about all knowledge workers, that the analytics are a way that enable people to work at the top of their license by taking tasks away and giving them higher level information. But the challenge with this framework is that the analytics don't operate in a vacuum. And if we want to get access to electronic health record data in a durable and easily adaptable way to access the right data, those methods don't exist, right? So the long and short of it is that we don't have methods actually to make this happen in an easy way. We have methods to get access to this kind of in real time, but they're not easy to use. And if we want to get access to all of this stuff, to orchestrate data flows that use data from multiple systems, that also doesn't exist. And so there are real barriers in feeding into this in a way that makes sense for a workflow and a data flow. And I would say go ahead, Gary.
What I was going to say is that, I mean, that really is the holy grail at this point. It's certainly getting the most attention. And fire, tends to address that, but that's a whole separate subject that we could probably talk another hour on. So we could, definitely continue that conversation over at the community on the network.
Yeah.
So.
Yeah, and I think it is probably worth talking about what methods do we have and what's available. I think the harder part of this is actually translating the output into something that's actionable. That's even harder, I think, to achieve with the technologies that we have with electronic health records, the back end of those technologies, the difficulty of using them, and the barriers to using them. All of those are challenges. I think for the interest of time, I'm going to just close with a few comments, and perhaps we can come back. But I'll just say that in all of the areas where you want to get access to data, there are barriers with the existing methods. The traditional methods of custom APIs, HL7, the emerging FHIR, the narrowness of the data that you can access, the enormous cost and burden in using those methods, the inflexibility, all of these are challenges, and it's worth even just having a discussion just on this slide because there's a lot here. And I would just close, I think, by let me just go to, at least how we think about what is really required to make it easy to use data in real time. And I think we believe that the process has to be much more self-serve, and not one where the IT department of a healthcare system is the only one that can serve things up. That is a dominant barrier. It's a benefit to IT departments and it's a benefit to data users if we can make things more self-serve, because that takes the work off of the IT department and it educates the users on finding data. I think like the rest of the world in other business sectors, we need no-code APIs. We should be able to generate APIs without a coder. And that's how the world outside of healthcare operates. And we certainly need that within healthcare. Being able to put applications into production in a short period of time, fundamentally important. And then all the things that you have to do around keeping up with changes. The source data changes, we should have easy ways of adapting to that. We should be notified when source data changes that we're using and have almost automated ways of adapting APIs for that. We learn from data. We learn from experience, our knowledge changes, so our data needs are going to change, and we should have easy ways of sort of managing through that in a way that that allows us to keep pace and to continue to easily offer a better and better product. So I'll just stop there. I know we're out of time, and ask if there are any questions.
Yeah, well, there was one question, but you kind of addressed it just now, which is could you elaborate with some examples on the data needs of EHR plus and EHR plus plus?
Yeah, so that goes to both patient-generated data, but it also goes to so patient-reported data in healthcare is very important. There's lots of areas of care that, like common episodic conditions like migraine, asthma, things of that sort, where we could do a lot better if we had patient-reported data on how the patient was doing to guide treatment decision-making. There's SureScripts data, invaluable, in immediately notifying us if a patient even bothered to pick up their script, or what their minimum possession ratio is. That could allow for some easy messaging. The fastest growing area of data are PDFs because of specialty pharmacy and diagnostics, and we don't really have easy ways of getting access to that. But if you're in the prior auth space, this is a barrier to automation. We know a lot more about, at least we have a lot more data about the care that people are using, but we don't really have access to it. So this is just a small list of the diversity of data that could be meaningful, but where we don't really have a way of piping into it and integrating it into a workflow.
Great, thanks, Buzz. I want everyone to know that this entire talk will be available on the MedLabs website as well as in GHIN in the InnoTalks community and some other communities. So it'll be accessible. The PowerPoint will be available as well. And we are creating Buzz is working with me a bit to create a data analytics community on GHIN, and we can kind of continue these conversations and even continue some of the questions there as well. I'd like to thank Buzz. Buzz and I have known each other for quite a while now, and Buzz is really just a wealth of knowledge, especially in this space. I would encourage people to check out Medcurio, his company, which deals with a lot of these issues. I'd like to thank ZGC and GHIN for sponsoring these talks, and I'd like to thank everybody for attending the talk, and look forward to seeing you at our next event.